Assalamu alaikum. Welcome everyone on board. Um, we will continue our discussion on gastrointestinal system. We started our discussion from the basic concepts with reference to gastrointestinal function, gastrointestinal secretions, and then common problems which we all deal with, like intestinal obstruction, aspiration. We discussed some points about ERCP. We discussed some abdominal surgeries like appendicectomy, cholecystectomy, laparotomy, which is yesterday we discussed some points about ERCP, endoscopy suite, and also we discussed some points about enhanced recovery after surgery. I just want to clarify one small thing which was a little need to be a little bit of clarification. We were discussing about monitored anesthesia care, and there was a point about MAC awake. So remember one thing, actually, for that you just need to be sure what is MAC. So MAC is minimum alveolar concentration, which will inhibit movement in 50% of individuals. So MAC awake is a little bit different. MAC awake is that above below which their patient can have awareness. So, like if you are and then MAC bar is the minimum alveolar concentration, which will inhibit adrenergic response. So it is blunt adrenergic response. So this is around, different books will say different. So it is around 2 MAC, and MAC awake is around zero point 0.3 to zero point 0.5. Like majority will say zero point 0.5. So this maybe I said for prevention of awareness, you need to have MAC 1. So it was not MAC 1, it was zero point 0.5. So I just wanted to clarify a little bit. So like uh, we discussed some points about abdominal compartment syndrome before. I will just repeat few of them, and we will just consider that what's the significance of raised abdominal compartment pressures to start with, and later on, because abdominal compartment syndrome we will label when there is newly development, not only the abdominal pressure increase, but it lead to an organ dysfunction. Okay, so without like without organ dysfunction, we will not label it as abdominal compartment syndrome. It will, we will say it as a syndrome when there is some development of organ dysfunction. Okay. Like, for example, during coughing, abdominal pressure increase. During sneezing, abdominal pressure increase. If there is constipation, momentarily there will be increased abdominal pressure. So, and we will not label it as abdominal compartment syndrome. Okay. So, similarly, there are some iatrogenic conditions after anesthesia. Like, for example, I will give you example that after anesthesia, after this abdominoplasty, or some other plastic surgeries. They put a band, like a tight dressing, elastings dress on the in the abdomen. So it can increase the airway pressure. So that is a little bit different. Okay. So similarly, another example is post liver transplant, especially in pediatric age group. Sometime when they are putting the transplanted liver in pediatric patient, the liver is a little bit big. Okay, so when they are trying to close the abdominal pressure can increase. So that's why they keep it open, and like open in the sense that it is a silastic sleeve in which they cover the abdomen, and gradually they um, uh, put close it over few days, or few like you can say up to a week. Like so, this is another scenario in which the abdominal pressure will be increased for some time. So uh, just a second, please. Okay, so Iqra, So you see, this is like these are the risk factors, or you can say etiology for a development of abdominal compartment syndrome. So, because there is a abdominal wall, so diminish abdominal wall compliance, like in acute respiratory failure, especially with elevated intrathoracic pressures, abdominal surgery with subjectively tight primary closure, major trauma, burns, prone positioning if the abdomen is not uh, free, head of bed elevated more than 30 degree, high BMI, central obesity, and then increase intraluminal contents as it occurs in obstruction or gastroparesis or ileus. Okay, and then abdominal increase abdominal content, like like when we create either this pneumoperitoneum, or if there is ascites. So either the wall compliance in the abdominal wall, intraluminal contents as occur in obstruction, and in abdomen, like which occur in pneumoperitoneum, so or ascites. And then if there is extravasation or leakage, like if, for example, capillary leak fluid, if you are giving too much fluid, or there is, so you see acidosis, hypotension, hypothermia, polytransfusion. So there are these are certain things in which the patient will be prone to develop abdominal compartment syndrome. Uh, So another important point, how to measure. Just I will, because we will just have a look. Just a second. I will showing you. Okay. So this is either Meyer intragastric, or if they are when they are doing laparoscopic surgery, they can measure directly. Or this is the way by which they are measuring through bladder. Okay. So I have never used it. So, but the concept is that they put a Foley there, distend the abdomen, and then they put a like they will clamp it, and they will measure through the pressure transducer. Okay, so this is how it will uh, show the abdominal pressure. So the organ function which will be is you see cardiovascular system, respiratory system, and renal system. Okay, uh,
You've done that.
central nervous system. Okay, so you see, what happens in the cardiovascular system, whatever is happening is either it will be increase in the SVR, or you can say the cardiac output will be affected. So you see, that's what they will tell. The pressure within the abdominal cavity is directly transmitted to the abdominal vasculature. The compression of venous system leads to venous occlusion and a reduction in preload, like a sort of autocaval compression, while arterial compression leads to reduced arterial compliance and increase afterload, as I mentioned you. This combination leads to a decrease in cardiac output. Okay, and often abdominal perfusion pressure. So when abdominal pressure, perfusion pressure will be reduced, the organs will have dysfunction, sort of ischemic uh, picture. The cardiac output may be further compromised by an increase in intrathoracic pressure due to diaphragmatic splinting and elevation. So it will, because the pressure is also reflecting upwards. The heart and great vessels are both compressed and distorted, thereby reducing compliance and contractility. The combination of increase in intra-abdominal pressure and decreasing cardiac output may rapidly result in catastrophic intra-abdominal ischemic injury and event. Like you understand, the basic thing, if you forget all this paragraph, the basic thing is that the both venous and arterial system, both will be vena cava system and aorta, both will be affected. Okay? Not in the respiratory system, because it's like it is pressing the thoracic cavity, diaphragm is raised, so airway pressures will be increasing, and there will be VQ mismatch. Okay, sort of atelectasis, basal collapse, increasing VQ mismatch, and decreased pulmonary and chest wall compliance, a feature of this condition. In combination, these factors lead to increasing hypoxia and hypercapnia. Because whenever the purpose of respiratory, like gas exchange, is to get the oxygen and uh, kick out CO2. Okay, both of them will be affected. Uh, like increased inspiratory pressures and PEEP will further compromise venous return and cardiovascular failure. So, uh, treatment of intra-abdominal hypertension has been associated with reduced ventilatory days in several studies. Like they, because if intra-abdominal pressure will be increased, so there will be it will directly affect respiratory system. Similarly, renal system. Because remember one thing, a number of places we all are tuned, keep the blood pressure above mean above 60. So we are missing something. So this is also a practical conduct in the practical conduct of anesthesia. Don't remember 60. Remember the word 80 because the renal perfusion pressure is minimum, like auto regulation is between 80 to 180. So whenever the blood pressure falls down below 60, below 80 mean, actually renal perfusion is decreased. So the evidence is that as an occurs in shock or as occur in trauma or as occur in any reason of hypovolemic shock, the brain will not have injury because the cerebral auto-regulation is between 60 to 160. Okay. But there will be renal shutdown. So, so for a good conduct of anesthesia, because even surgeons also remember only know the 60. So they are also telling keep around 60, keep around 60. But remember, if you have any patient who is at risk of renal impairment, please keep the minimum mean arterial pressure not less than 80 because it will result like a patient with history of NSAIDs, patient with history of arthritis, patient with history of diabetes, patient with history of hypertension. So any renal risk, renal impairment, and now you are overburdenized. So remember this word. So the same thing they are telling here. The increase in intra-abdominal pressure and subsequent decrease in cardiac output are reflected in renal blood flow. Okay? So reduced renal blood flow is not the sole cause of renal dysfunction. There are some other thing to the renal outflow tract. So as pressure increases within the tubular system, this is inevitably transmitted back to the glomeruli, reducing the filtration gradient. The filtration gradient is the pressure difference between the abdominal perfusion pressure and proximal tubular pressure. If the abdominal pressure increases above proximal tubular pressure, which is around 15 to 18 millimeter mercury, then there is increased resistance to filtration and decreased urine output. Like for filtration, the afferent and efferent arteriolar system, there is a pressure gradient which is leading to the development of GFR. So this is not only because of decreased renal blood flow, this is an extra effect which will affect the lead to renal dysfunction. Okay. So mean arterial pressure minus intra-abdominal pressure. So if it is increased, so that's why it has more effect. So it can be seen that when abdominal pressure is elevated, the intra-abdominal pressure acts in two independent ways on the renal system. So you don't need to remember in that way, but you can now how to depict this, that not only decrease the renal perfusion pressure, it also affect the filtration gradient. So GFR will be decreased. Okay. Intra-abdominal hypertension will affect the ICP. So that's what. So in traumatic brain injury or any condition in which raised ICP is a problem, you have to take care of it. So that the whole summary will be around it. Elevated intrathoracic pressure inhibits venous return with a consequent increase in intracranial pressure. Associated hypercarbia and any consequent cerebral vasodilation may also have an additive effect. So that's another point. So this is just a summary about like increase intracranial pressure will have effect, increase systemic SVR. increase PVR, decrease venous return, decrease cardiac output. Respiratory increase VQ mismatch, atelectasis, decrease shelf wall compliance, increase airway pressures, increase it will all result in low PO2. Similarly, as the same, it's very replicated nicely in this flow chart. Increase renal tubular pressure and urinary obstruction, sort of thing. Decrease renal blood flow and urine output. Gastrointestinal system, increase celiac, mesenteric, hepatic, and portal blood flow. Increase edema, bacterial translocation, and liver dysfunction. So they all have effect. So same thing is written here. Uh, Hepatic blood flow within the hepatic artery, vein, and portal system is also adversely affected, leading to mitochondrial dysfunction. This is like the main summary is like that because in critically ill patient already they are the chances of ileus. So especially if the patient is on for any good reason uh, like a TPN. So all these factors will result in development of like uh, uh, these are risk factors for even development of sepsis because bacterial translocation will occur and it will lead to even it will further deteriorate the problem. That's why remember one thing, bowel ischemia is a leading cause of mortality, morbidity, following other things. Like you are able to, if the patient was in shock, you gave a lot of vasopressor to control the blood pressure, but you are forgetting that it can cause bowel ischemia. So you will find so many times same picture. Now, all of us in our career would have dealt with such condition. A patient who was on vasopressor for a certain period of time because of multi-organ dysfunction, and now the patient has developed gut ischemia. And now, if even if there was any chance of survival with this bowel ischemia and all this thing, there will now the chances of survival will even decrease. So this is very important. Similarly, it's very important to keep volume status very good and perfusion. There should be a balance between hypoperfusion and gut edema. Like if you are there is dehydration, even then there will be problem in healing of anastomosis. But if there is gut edema following any gastrointestinal surgery, even that gut edema can lead to anastomotic leak. I hope you understand. This is important point. Healing of bowel and osmosis in abdominal wounds is impaired, leading to an osmotic and wound breakdown. This is not only because of one factor is ischemia, but the other factor, which is not written here, but I'm just telling you that another factor is edema. So there should be a uh, like balance between the two things. Okay. So there will be a treatment. So it's there is no specific treatment. So relieving the pressure both sides from like NG or making head side a little up and sorry, supine positioning, decompress the stomach, okay, and avoiding the stasis like enemas, flatus tube, and prokinetic agents, they will all benefit. Cuffing, straining, and ventilator dyssynchrony. That's why I say because if there will be stacking, it will also increase the and abdominal pressure. But remember one thing. Now again, this is another thing we should be taking. You should be taking care. If you are using because dealing a patient in ICU is just like an octopus. You if you are holding one leg, the other leg will come. So, for example, if you follow only this ventilator dyssynchrony and you are giving muscle relaxant, you excessive use of muscle relaxant will lead can lead to this critical illness this myopathy. So you again that's why like you have to bring a balance. So you cannot do only one thing. Okay. So uh, this is okay. So organ support will be through not only increasing the blood pressure, taking care of SVR, taking care of contractility, cardiac contractility. So all these parameters will be important. Um, So you see the CVP, because traditionally we all are taught about CVP, but CVP will not be a very good indicator, especially in these conditions. It will giving falsely elevated. Okay, so stroke volume variation as measured through like intra-arterial blood pressure monitoring or cardiac output monitor will be a better way. And then monitoring the like signs of volume status clinically will also have another, uh, it will give a better control. Also, this one, you, um, what I was saying, I forgot what I was saying. Urine output. So, urine output will also uh, be a good indicator. Okay. So, similarly, like if there is overload, if a patient is fluid deplete, but the target abdominal perfusion pressure of 60 has not been reached, then inotropic or vasopressor should be commenced. There is no clear evidence as to which inotrope or vasopressor. Like again, I told you all the aspects that you have to bring a balance. If you are using too much vasopressor, that's also a problem. If your volume status is not good, even that is a problem. If there is overload, again, it's a problem. So and then if for example if you need renal replacement therapy and all other things like lung protective strategies or anything like that. So, enteral feeding should be continued in all patients if possible to maintain gut integrity. Okay, so because if you are not maintaining this enteral feed, it's also a risk factor for a number of things. So this is an important, also an important point. Surgical management, if surgical intervention is needed, like sometimes they keep the decompressing the abdomen, laparotomy. Similarly, you see, that's what I was saying, the stylistic, the Bogota bag, when they want to keep the abdomen open. Okay. In the strict sense, the abdomen is not left open to the air, as it would lead to drying and dehydration and desiccation of bowel. Instead, a plastic membrane or Bogota bag, silastic sulu is also like that, uh, to cover the wound edges. After the abdominal cavity is simply a large closed compartment, and further increases in volume may still result in an increase in intra-abdominal pressure. Okay? Therefore, pressure monitoring should be continued. In one, like they are just repeating the same thing which I was saying. Another important point, just with reference to abdominal decompression, this is also important practically, not related to abdominal compartment syndrome. But remember one thing, that whenever you are dealing any patient, any such patient in the operation theater, whether it is ascites or gas or for any good reason, the intra-abdominal pressure is increased. And now suddenly it will be deflated. So remember one thing, suddenly, especially if there is fluid shift, patient will suddenly decompensate. Okay. So you have to replace the volume, because if you don't replace, there will be sudden change in cardiac output, and maybe it's not well tolerated in a patient with limited cardiac reserve. So that's why this is very important. Okay, so you see, on opening the abdomen, after load will fall, as may cardiac output and arterial pressure. This may profound, resulting in sudden cardiac arrest. This is what I was telling you. So it's very, very important. So I think this is enough about abdominal compartment syndrome. And let me show you. This was another. It's a very good article. And the problems. Can anyone tell what are the gastrointestinal problem which we face in ICU? Now some interactive thing. Faiza or Sajid, anyone wants to speak out? Faiza, what what gastrointestinal problems we can face in ICU or in our perioperative period?
Sir, ILS,
ILS,
diarrhea,
diarrhea.
or sir,
Diarrhea is like diarrhea can occur, but actually ILS is more. Then aspiration. Okay. As we are discussing, or we were discussing abdominal compartment syndrome, ulcer. Like stress ulcer, not only because of stress, a number of patients they are using steroid, so this is also leading to ulcer. Ileus is a problem. Aspiration, micro aspiration, actually not full blown aspiration, but it is prevention of micro aspiration is also for the prevention of VAP. It's not only for prevention of VAP, also for sepsis. Okay. So, it's very important. Then abdominal compartment syndrome we discussed. What else? You see, uh, obstruction, ischemia, perforation, hemorrhage, or stress-related mucosal bleeding, intra-abdominal compartment syndrome, as we pancreatitis. Of course, these pancreatitis and cholecystitis, this can occur with reference to multi-organ failure also, but usually, these are the things which some of them we have already discussed. Similarly, you see, mm, prevalence of bowel symptoms and signs in ICU. We have discussed about this intra-abdominal pressure. Of course, these pressures, numbers, I am bad in remembering the numbers. So you should be knowing. Usually, if you forget, remember around 10. Anything around 10, same for CVP, same for ICP, same for IOP. If you forget the exact numbers, remember the word 10. CVP is around 10, pulmonary artery pressure is around 10, ICP is around 10. So this is a sort of mean sort of thing. So this is grades of intra-abdominal hypertension. One, two, three, four, and more than four, it's serious. Uh, we have discussed these some of the points. Mm, Okay, so I think this is with reference to, like, as I told you, stress related. So mechanical ventilation, coagulopathy, and then minor risk factor, hypotension, sepsis, liver failure, renal failure, trauma, burns, and steroid. They have written is as unclear risk, but actually, can you tell me how steroids lead to ulcers? Yes. Oh, I'm sorry, I was disconnected. There was some problem in the internet. So my question was, can you tell me how steroid effect like lead to ulcers? Yes, Faiza or Sajid or Albar, anyone? Can you hear
Sir,
me?
no idea.
Think. Steroid. Okay, what is the mechanism of action of steroids?
Sir, it can cause immunosuppression. So,
Do they affect on the inflammatory mediators and prostaglandins? Yes, please. So actually, these protective prostaglandins are inhibited. Same is true with the this NSAIDs. So they are leading to, when this protective mechanism is gone, there will be chances of ulcers. Okay. Uh, okay. So I think because inshallah we on Saturday we will do liver. Inshallah, Saturday I have. strong will to do liver. So some of the topic, another topic actually, which is a little uh, atypical. I will just show you. Just a second, please. What is mechanism of action of proton pump inhibitor? Yes, Faiza or Hasham, you have just joined. Mechanism of action of PPI. Nobody?
No, sir, I can't recall at this time.
Remember any medication which we are using frequently, you should know the mechanism of action. Okay. So if I'm not wrong, there is a proton pump, which is like putting um hydrogen inside the mucosa. This to form the gastric acid, it's inhibited. So there is no movement of hydrogen ions towards in that direction. So it will lead to lack of formation of uh, gastric acid. So remember one thing. So like actually we did not discuss about this thing. I will tell you a few words about this how we control this, because one mechanism is PPI and H2 receptor antagonist. Okay, both are decreasing the gastric acid formation. Okay, but they have no effect on the already formed acid. So for that, which medication we give? For the already prepared acid, what we give? This bicarb, like this antacids. I'm sorry, not this bicarb, antacids, non-particulate antacids. Okay, so this is the second thing to neutralize the pH, because pH less than 2.5 is critical, volume more than 25 ml is critical, or 0.5 ml per kg, as in pediatric patients. So this is thing, and now so the further production will be decreased by PPI and H2A receptor antagonist. Neutralization of pH will be done by these antacids and prokinetic agents. Okay. Can you tell me some prokinetics? Yes, Hasham, Faiza, anyone?
Sir, erythromycin,
Very good.
sir,
Erythromycin.
erythromycin, metoclopramide,
Okay. Metoclopramide. Domperidone. Cisapride. Okay. These are some of the prokinetic agents. So they are increasing the gastric motility. So this is another factor. And so these three directional thing we do for the prevention of aspiration. Mm, So also this is a good revision of upper GI bleed. So can you just tell me the differential diagnosis of upper GI bleed? Few words.
Sir, it could be due to esophageal CA और मुझे एग्जैक्ट याद नहीं आ रहा सर अभी
CA.
medullary
What?
waist tear or any neoplasm or any trauma.
You are not telling the simple thing. Bleeding disorders, varices, carcinoma,
Disorder.
trauma.
Liver
This
liver
is
disease.
ulcer.
Yeah.
These 4, 5 are enough. You are using a very difficult Miller-based tree. How common it is? Okay, so I don't think so. They need 10. They need the common one. So ulcer, varices, bleeding disorder, carcinoma, trauma. I think this is more than enough. This will pass you. I can guarantee you. And whether it is upper GI bleed, uh, can if it is vomiting, it will be coming as hematemesis. Okay, if it is not, it is going down. It will cause melena. Okay, or you are not able to identify if it's going uh, chronically. Maybe it's presenting as anemia. Okay, so if it is sudden, there will be hypovolemic shock. So this will be so some history points will be telling you may be the possible etiology. Okay, there may be history of bleeding disorder like von Willebrand disease or hemophilia or like any other problem with reference to anticoagulants or antiplatelets. So all can cause bleeding tendencies, liver dysfunction, renal dysfunction. Okay, they can all lead to bleeding tendency. Use of steroids, use of NSAIDs. So these are you will just make the list, and you can easily tell if you are in thinking conceptually. Okay, so what else they have written here? Let's see. Hmm, okay. So actually, if we go one by one, so I have discussed some of them like airway, breathing, circulation, assessment of volume status, how much is the like loss, and then either you will be going like they will be doing through this Sangsticken Blackmore tube. Okay, either they are doing this sclerotherapy, they are putting band. Okay, this is something new for me, cyanoacrylate glue or thrombin injections. Okay, so these are endoscopic rubber band ligation, sclerotherapy, glue, or thrombin injections, or the you medical this pharmacological management through octreotide or terlipressin, a vasopressin analog, which is causing sort of vasoconstriction, reducing the risk of further bleeding and are useful adjuncts to endoscopic interventions. Balloon tamponade. In the same time, you will have this antibiotic prophylaxis, H. pylori management if it is it's related to you see like H. pylori infection with H. pylori and medications such as NSAIDs, SSRI, and corticosteroids. So airway, breathing, circulation, assessment of the situation, and as we discuss according to the possible cause. What else they have written here? Endoscopy, CT angio, angiographic embolization, or laparotomy. The preferred strategy will depend on the clinical condition, available resources, and the therapeutic intent what they want to do. Okay, fresh hematemesis can result in life-threatening catastrophic blood loss and require simultaneous resuscitation, investigation, and definitive treatment. Age, shock, comorbidities, and rebleeding predict mortality. Treatment principles of catastrophic. Actually, I'm just cause usually I don't read the text. Usually, I want to tell extempore, but since it's in front of me, so I'm just seeing maybe it's a recheck for me as well that whatever I'm telling, uh, what will be the role of vitamin K in acute like liver dysfunction? Will it affect immediately?
So it usually take 1 day.
Okay,
It
but still we give. Okay, still we give. So if we want to for immediate correction, which things we can use? Yes, there
sir,
are
the
three things.
FFP.
FFPs, what
Sir,
else?
FFP,
FFP,
uh,
cryo, and
sir,
prothrombin,
exmopressin or
prothrombin
prothrombin.
complex concentrate. Okay. And vitamin K. Okay. And what else? Of course, PRPCs we will give. And one thing, if nothing is working for bleeding tendencies or bleeding, these are the thing. What else? Can you tell few more things?
Factor 7,
FFP,
sir.
Novo 7. It has role in the cell-based theory. It not only initiate. What is the second step? One is initiation. The second is amplification. And the third one is propagation. So it has major effect in these two. It all not only initiate, you can say it's like nothing is working, so it's like an atomic bomb. So it's the last resort. What else for the bleeding tendencies and bleeding problems? Platelets. What else? Tranexamic acid. Which bedside investigations you can do in the same course because this is just exercise because the situation may be different. This may be asked in massive bleeding, this can be asked in placenta previa, this can be asked in as we are discussing here. What are the point of care testings? What is the concept of
The
point of care
tag.
HEG or rotem?
Bottom.
Okay, what else? There is two more tests you can tell. Actually, there is bedside INR as well. There is bedside ACT as well. Okay. So ACT can tell about uh, which thing it will tell. Heparin or APTT. It's like APTT. And INR is like warfarin or vitamin K dependent. Okay. So this and only few words about this. There is one reaction time. There is one angle. Okay, and then there is one maximum amplitude, and then there is hyperfibrinolysis. So if reaction, like it's more taking more time for its reaction, what thing we need to give? What's the problem? Then there is alpha angle. What's the problem? Then maximum amplitude. What's the problem? Then this fibrinolysis. So can anyone tell? Hasham, Faiza, or Sajid? Anyone, please?
Sir, if the maximum amplitude is decreased,
Start with
we
reaction.
need to give the platelet.
No, start
We
with
need to give
reaction.
the platelet.
No, start with reaction time. R, what will you give here?
Sir,
Sir, we need FFPs for this. I think so. To
FFP is
start.
coagulation factors, like, okay. Alpha angle,
sir, platelets.
no. You
Alpha
told
angle
the correct
decrease
here.
or maximum amplitude.
No. Maximum
Maximum.
amplitude is platelet. And alpha angle, it's fibrinogen. So which is the best source of fibrinogen other than fibrinogen concentrate? Cry-
Cryoprecipitate.
Cryoprecipitate. Okay. And for fibrinolysis, what will you do?
Transamine acid.
Can you tell me the mechanism of action of tranexamic acid?
Sir, antifibrinolytic.
Don't tell me this thing. Tell something further more than this. This is long case. Okay. This is the way they can ask you, because they just want you to know why you are certain medication, why you are using certain medication, why you are very good, very good. Yes, it's like this. Actually, it's inhibit the conversion of plasminogen to plasmin. So plasmin is the machine which is breaking the fibrin. So when there will be no plasmin, there is more formation of fibrin clot, and it helps. So remember one thing, you will see people using or asking tranexamic acid like green tea. They are asking you to give like GABA. Okay. So actually, it has no effect on vascular bleed. It is only for oozing, because it will have effect on this micro bleeding. Okay. Not like if there is venous bleeding and they want asking you to give tranexamic acid. What are the problems associated with tranexamic acid? Can you tell me?
Excessive clot formation occurs.
So which vessels will be at risk during anesthesia? It's one of the risk factor for transient blindness because of retinal tiny retinal vessels. Okay, so tranexamic acid ideally should be given in infusion, like it's around 10 milligram per kg per hour, roughly. And it's being used in a number of surgeries, orthopedic procedures, joint surgeries, spine surgery, when where there can be oozing. So this will be an important thing. Okay. So in this discussion, we discuss some important points, not only about this management of upper GI bleed. So just now you can recall airway, breathing, circulation, assessment, management, evaluation of the situation, etiology, possible etiology, like they will be giving esomeprazole infusion, they are giving antibiotics, they are trying to replace the fluid with crystalloid or colloids or PRBCs, and then they are trying to find out the exact reason and to replace to act accordingly. Okay. Okay, so similarly, this is about stress ulcers. Is thought to result from gut ischemia due to hypotension, vasoconstriction, or inflammatory mediators, and increase intraluminal acidity in acute illness. This is with reference, actually, this is some new terminology which I never read before. Stress-related mucosal damage. Okay. Because major stress-related increases ICU stay and mortality. Stress ulcer prophylaxis should be used for all patients with major risk factors and considered for those with minor risk factors. They have written here in just a second. Here, I think these are the risk factors which we already discussed here. Okay, so PPI prophylactic regime, PPI H2 receptor antagonist. Uh, PPIs may reduce the risk of bleeding, but they do not reduce mortality compared to H2 receptor antagonist. ACE suppression has no effect on the rate of nosocomial pneumonia, but may increase the rate of Clostridium difficile infection. Early enteral nutrition may decrease the risk of upper GI bleed, especially SRMD, this stress related. So, buffering intraluminal acid and promoting secretion of cytoprotected prostaglandin, uh, but like it is with enteral nutrition. Okay, but it's unclear if enteral nutrition is sufficient protection in high risk patients. Like it's one of the factors. That's why, as I told you, that in ICU there are so many factors which need to uh, consider. In lower GI bleed, all the common things will be the same. Same variceal bleeding can occur, bleeding disorder, trauma, CA. So anything can like that. Some specific will be like polyps, diverticuli, and fecal containment devices. rarely from aortoenteric fistula. Upper GI sources of brisk bleeding account for hematochezia. It's fresh blood, okay? Fresh, acute, bright blood PR. So high risk patients include age more than 60, shock, significant comorbidities, NSAID, aspirin, and then the same initial resuscitation and treatment as per upper GI bleed, with investigation including colonoscopy, CT angio, red, but this is something new for me. I don't know what is it. Red call scan. I'm sorry, what is this? Mesenteric angiography, embolization or surgery are indicated. Remember one thing. These are little difficult things or very specific things. So these are not failure points. Okay. So the main thing is that your approach should be the generalized, in which you are covering the basic concept. These Remember one thing, if you just try to cram these words, I don't think so they will benefit too much. So don't waste your energy in like you just try to cram this word. Okay? Then that's the problem, unfortunately, because you will use your energy in memorizing this nuclear scintigraphy, and you will forget something very simple. So I never try to cram these words. I try to understand the basic concept. So I will tell you the same thing. Okay. So some of the other problems like constipation, delayed bowel motions are common in ICU, as we discussed, gastric motility. We have discussed a number of sedative opiates. It has a very bad effect on gastrointestinal outcome. Not only it will lead to ileus, it will lead to vomiting. Vomiting can cause retching. Retching will have bad effect on anastomosis. Okay. So similarly, it will cause respiratory depression if you are using it for a prolonged time. And it has like if, the most common medication which is available in majority of hospitals, at least in some developed countries, is for example fentanyl. So fentanyl infusion initially, when we are using fentanyl for a short period of time, there is no problem. But elimination half-life and fentanyl, because fentanyl is highly lipid soluble, so it has very long context sensitive half-life. Okay, so can you tell me what is context sensitive half-life? Yes, Faiza. What is context sensitive half-life? If you are giving something in
No, sir,
infusion,
no idea.
Faiza, just try to note down the things and please do, because these all are interlinked. And remember, in the long case or in the exam, you consider yourself sitting in a roller coaster. So if you tune your brain, and you don't need to know too much details, like in a very simple way, context sensitive half-life is that when you are giving something in infusion, so the time when you stop the infusion, the the time after that, in how much time its effect will go. Simple words. So if when the among the medication which we use, the shortest context sensitive half-life is for remifentanil, because it is like destroyed by the plasma, in the plasma by plasma esterases. Okay, so no matter for how much time you have given, when you stop it, patient if will suddenly wake up. Rather, it can cause reflex hyperalgesia, because it will. That's why whenever you are using remifentanil, when you are stopping it, before that you need to replace the analgesia. You need to replace some sedation. Otherwise, patient will become suddenly awake. Fentanyl, because it's highly lipid soluble, it will go in the fat. So if you are giving it for hours to days, now the context, according to the context sensitive half-life, it will take a lot of time for it to be eliminated. So it can cause delayed in recovery. Okay. So that is the concept of context sensitive half. I repeat, that duration by which the effect will be reduced, will be gone, the plasma effect will clinical effect will go after we stop the infusion. Okay. So as the duration will increase, it will have some effect on some medications, we usually propofol, for example. So propofol, if you are using in infusion, gradually the contact sensor, the more duration we are giving, the more time it will take to get up. Also, though it's not as long as fentanyl, but it will also increase. And if you are using multiple medications, so then the recovery time will be delayed. Okay, so it will have synergistic effect. So, and the synergistic effect is 1 + 1 is equal to 3, not 2. So this is the concept of, like, if you are using multiple medications, or if you are using for a long time. So, so from where, like, that's why, remember these things, that when you are preparing for the exam, you cannot remain in one topic, because in the exam they can ask suddenly, like, we are discussing something else, and suddenly this word is coming and I'm telling you that thing. So same is true in the exam. So try to practice in that way. Okay. So I think we will just finish in next 5 minutes. We will finish. So I don't think so. There is something you can have. I will. This article is a very nice one. And another medication which they use is lactulose. Okay, lactulose also prevent for the constipation. Lactulose is one of the medication for prevention of hepatic encephalopathies, or uh, like number of conditions lactulose is being used. Diarrhea, causes of diarrhea in ICU include drug, laxative, antibiotics, uh, enteral nutrition, but diarrhea may also indicate a serious disorder such as infection or pseudomembranous colitis from Clostridium difficile. Diarrhea affects fluid and electrolyte balance and causes perineal exhaustion. Treatment involved addressing the underlying cause and replacing fluid and electrolyte. Bowel management system very ineffective in preventing. So I think we have. Let's see which topics are left. Tomorrow, inshallah, we will discuss pancreatitis, and day after tomorrow, inshallah, we will discuss liver, inshallah. So just let's have a look. We have started our journey from here. Hiatal hernia, I have not prepared. I mean, we will just try to, because I was thinking to do necrotizing enterocolitis, but we will discuss it with here. Congenital diaphragmatic hernia, tracheoesophageal fistula, and necrotizing enterocolitis. These are all in prematurity. We will discuss along with prematurity. So we have discussed a number of things. I think plus 2 days we will all we'll discuss. Esophagectomy, when we were discussing esophagectomy, is actually like, they will not be asking you the steps of esophagectomy, but one thing you should not forget, that esophagectomy, there is one abdominal approach and one thoracic approach. So if they are doing through thoracic approach, they need to have the one lung ventilation. So this is something you should not forget. Esophagectomy, also there is an article. Just I will show you. This was a long case for me. Pregnant patient with CA esophagus for esophagectomy. So this is a patient. This is a case. They can ask you. I was just thinking. Just a second. This is an old article, but main points you can have a look from here. Actually, the major things, if you want to, this is another way I tell you something, that if you don't want to read the whole of the article, see from the inside and this key points. Like, if you open the folder, do have a look on these key points. You will believe me, at least you will have an idea. Like you see, we will just have a look here. A subject associated with 40% morbidity, this appropriate anesthetic management can preoperative assessment using a scoring system can help determine the appropriate anesthetic and surgical management and level of post-operative critical care required. Direct arterial pressure, CVP, urine output, temperature should be monitored during all esophageectomies and should be adequately trained and competent in one lung ventilation, fluid therapy, and thoracic epidural analgesia before they undertake anesthesia for esophagectomy. Post-operative analgesia should enable the patient to move freely and cough effectively. Okay, so these are the just an idea, nothing very specific. These are just basic concepts which you will be seeing in any abdominal surgery and even thoracic surgery. So now you see, so it can be approached by either right or left transthoracic or a transhiatal incision. The transthoracic approach allows good visualization for en block removal of esophagus and adjacent lymph nodes, and perhaps it's more likely to result in a cure. It is usually facilitated by one lung ventilation. Okay, a right thoracotomy with laparotomy, the classic approach, Lewis Ivor Lewis approach, is suitable for tumors within the upper two-thirds of the esophagus, and left thoracoabdominal incision is suitable for tumors within the lower two-thirds. The transhiatal approach, you can just have a look. Like this is the thing which you usually don't know. Okay, so if you want to just understand, just read. Don't need to read all each and every line. You just read here. This is the chunk which you usually will not know. Otherwise, the same, any thoracic or abdominal surgery with big incision needs good post-operative pain relief. Otherwise, patient will not be able to be weaned off the ventilator. Patient will not have a good outcome. So these are the same things. Uh, so this is one thing and one lung ventilation, if you just want to. Otherwise, because in esophageal diseases, like a tumor, patient will not be able to eat properly, so there will be nutritional deficiency, anemia, and all the sequelae. So uh, this will be common thing in all other this one. And because there will be etiology, you see, main esophageal concept, poverty, poor nutrition, alcoholism, smoking. Okay. Of the intrinsic esophageal disease, eclasia and Plover-Vinson syndrome associated with squamous cell carcinoma and Barrett's esophagitis associated with adenocarcinoma. This is also a high yield point which they can ask you. Okay, so okay, so this is the main folder where all the articles related to tomorrow. Inshallah, we will try to discuss pancreas, pancreatitis, acute and chronic, and what will be the surgical indications for if you can read about two, three things, pancreatitis, ICU scoring system. Okay, and we will just try to again, don't be afraid that, oh, there are eight articles, sir. How we will be reading? There will be common things. There will be concept and conceptual study. You don't need to, again, I repeat, don't need to read each and everything. Open, have a look. Just like for a females, I will tell, just like window shopping. You go to eight shops and you will buy from the ninth shop. Okay. So the same thing is there. You don't need to just do window shopping. Just have a look what's written. So that's how. Okay. So thank you, all of you, for tolerating me, and see you tomorrow, inshallah. Okay. Exam candidates are requested to ask anything, anytime to me. Okay. Bye bye.